Good morning, everybody, and welcome to the first in our series of South East Perinatal Mental Health webinars for 2022. Can I just remind everybody about housekeeping? We're expecting a lot of people on the webinar today, so just so that speakers can be heard clearly, please can we ask everybody to mute your lines and turn off your videos unless you're presenting. Please raise your hand if you want to ask a question, and also please use the function within the chat box. And just to remind everybody that we are recording the webinar today for those that aren't able to join us now, but will be able to at a later stage. So just a reminder, cameras off if you're not presenting, and please can you put yourselves on mute? Thank you very much. Okay, so we are just going to do some quick introductions. So hopefully a lot of you will know Jenny and I, but for new people that are joining us today, so I am Liz Cullen. I'm Head of Clinical Delivery for Perinatal Mental Health within the South East Mental Health team. And I'll hand over to Jenny to introduce herself.
Good morning, everybody. I'm Jenny Walsh. I'm the Clinical Lead for Perinatal Mental Health for the South East region. You won't be hearing very much from me today because we've got such a lovely selection of speakers this morning, but I'll be popping up in the chat. So I'll say hi and bye and see you all later.
Thank you very much, Jenny. So just to remind people, please, as they join, if they could put their cameras off unless they're presenting, and also keep themselves on mute. There's a little bit of background noise. Okay. So in terms of our agenda for today, really packed agenda as always. We've got some a privilege to have some fantastic speakers. So we're going to start off with Zoe Muliu from the national team, who's going to talk to us about supporting mental health and psychological well-being during and following perinatal loss, giving an introduction to the maternal mental health services. Then Mark Harder and also Emily are going to talk about both the work of SANS and the National Bereavement Care Pathway, and Emily is going to share her story. So a real privilege to have Emily with us today. Then we've got a recorded presentation, which is from the Birmingham and Solihull Maternal Mental Health Service. So unfortunately, they weren't able to be with us today, but they have sent us a presentation and a recording to go with that. So we will show that, and fingers crossed that all the technology works. And then we will just finish off with some of the resources and training available. Okay, so just a reminder, if you're not presenting, please put your cameras off and please put yourselves on mute. And without further ado, I'm going to hand over to Zoe, who's going to give us a nice introduction. Thank you very much, Zoe.
Thank you so much, Liz, and good morning, everyone. I'm Zoe Muliu. I'm a program manager working at NHS England and Improvement in the national team. I actually work across two different teams nationally, the perinatal mental health team and the maternity and women's health team. And I've joined the organization about a year ago. And today's webinar, as Liz said, is focused on the support provided to parents following perinatal loss. So I'm going to talk. Next slide, please. Oh, the next one. Perfect. So I'm just going to talk briefly about the nature and uniqueness of perinatal loss. Today we're going to hear Emily's story. Emily is Joshua's mother and chair of Fun and Birth SANS. And thank you so much, Emily, for joining us. We will learn about the National Bereavement Care Pathway, which is an initiative developed by multiple partners to improve the quality and consistency of bereavement care received by parents in NHS just after loss. And we've got Mark Harder joining us today from SANS. And we will also highlight how the new maternal mental health services can complement this offer to provide support to women who go on to experience mental health issues And I'm going to focus on that because it is my area of work, and it's a program of work I've been working on for the past year. Thank you. Next slide, please. So in order to put the MMHS program into its wider context, I just wanted to share an extract from a good practice guide that was published in July last year. It's called Supporting Mental Health Care in a Maternity and Neonatal Setting, and it includes a series of case studies. And I would highly encourage everyone to read it if you haven't done so. It has been produced by the University of Liverpool with people with lived experience, and it is a very good resource to further embed mental health within maternity and neonatal settings. And the chapter on perinatal loss aims to complement the National Bereavement Care Pathway, which will be presented by Mark Harder. And it focuses on key features of care that will specifically support mental health and psychological well-being. So it reminds us that the experience of perinatal loss is unique to every individual. It will be influenced by an individual's history of relationships, of loss, of pre-existing mental health difficulties, previous pregnancies and parenthood, and by the wider sense of self. So no assumptions or judgments should be made about the path that an individual's feelings or reactions might or should take. And it's very important that grief is seen as a natural and important process, which each individual will navigate in their own way. And staff need to feel comfortable in supporting individuals who are distressed. However, we also know that for some individuals, grief can become much more complicated, particularly when the loss happened, was experienced as traumatic. And for those who have pre-existing psychological vulnerabilities as well, or who have had a particularly traumatic experience of loss or poor care, there is an increased risk of more complex and severe mental health difficulties developing. So in any scenario following loss, staff and parents benefit from being aware of the psychological and the physical recovery process. They benefit from having the skills and confidence and resources to identify more complex grief reactions, and they should be able to access appropriate specialist support. Next slide, please. However, back in 2018, we realized that specialist support wasn't always available for women who experienced perinatal loss and who develop mental health difficulties. So NHS England and Improvement ran consultation events with a range of partners and stakeholders ahead of the publication of the NHS long-term plan. And one of the key findings was that some women who were experiencing moderate to severe or complex perinatal mental health needs were falling through the gaps in existing service provision. And presentations included PTSD following birth trauma, the severe fear of childbirth, also known as tocophobia, and PTSD following perinatal loss or the removal of a baby. And like when we're talking about perinatal loss, we're talking about loss for any reason, including early miscarriage, recurrent miscarriage, stillbirth, neonatal death, termination of pregnancy for any reason, or parent-infant separation at birth due to safeguarding concerns. And in 2019, SENS published a report called the Out of Sight, Out of Mind report, which showed that 60% of bereaved parents felt that they needed specialist psychological support for their mental health, but they were not able to access it on the NHS. So in summary, it was found that some women needed specialist perinatal mental health support beyond the support provided by other services, such as counselling or bereavement care services, and that in most areas, these women were not meeting the criteria to access support from the specialist community perinatal mental health services. And this was particularly true for women who had experienced perinatal loss. Next slide, please. So following these consultation events, the maternal mental health services were proposed to offer timely access to specialist assessment and evidence-based treatment with a focus on psychological interventions in line with NICE guidance to women having moderate to severe or complex mental health difficulties directly related to trauma or loss in the perinatal context, and also falling through the gaps of existing service provision. The maternal mental health services are also designed to influence other services and help to implement a psychological and trauma-informed care approach outside of the service itself. So this involves, for instance, providing support, training, or supervision to staff working in maternity and neonatal settings, but also GPs, health visitors, and so on. The ambition itself was included in the NHS long-term plan, as well as the NHS mental health implementation plan. The MMHS were then referred as maternity outreach clinics, but the name has changed, and the access figures will contribute to the overall national perinatal mental health access ambition. Next slide, please. So that's just a quick overview of the rollout of maternal mental health services. We have selected 33 early implementers and fast follower sites in 2020, 2021, and 2021-2022. The national rollout is due to start in April this year, with the ambition to have maternal mental health services developed in all ICS areas by 2023-2024. There has been a big emphasis on co-production arrangements with people with lived experience. So many MMHS have worked closely with voluntary and community organizations, or they've created co-production advisory groups, for instance. It was very important to have the experience of people with lived experience at the heart of the development and the design of the new services. And many services also recruited peer support workers, and we have recently organized a webinar on this topic to share learning and good practice. We've also funded a range of projects to tackle health inequalities. So, for instance, data collection and analysis to better understand population needs, cultural awareness training for staff, initiatives to make the service more accessible to certain population groups, etc. And the MMHS should also offer assessment and signposting of women's partners. So partners may also be involved in the care offer where the intervention relates to the wider family. So for instance, couple or family therapy. And finally, there is a national evaluation going on. It's being led independently by the ARC South London team, and the first findings will be available in April 2022. This year. Thank you. Next slide, please. So from the off, maternal mental health services have been encouraged to work with existing pathways and services for women who have experienced perinatal loss, because there may be, areas of overlap, but there may also be great opportunities for joint working. So existing services may include bereavement midwifery teams, rainbow service for women in pregnancy following a previous loss, psychological services embedded within neonatal units, and services provided by the third sector. And the boundaries between the services, these services listed and other pre-existing services, and the maternal mental health services will vary depending on the area, but it is essential that a specialist service is available to women experiencing moderate to severe or complex mental health issues across England by 2023-2024. That is the ambition that we're trying to achieve. And this also applies to women who experience birth trauma or tocophobia. So for instance, if the MMHS is focused on perinatal loss, there must be a specialist service for women who have suffered from birth trauma and who experience moderate to severe or complex mental health issues. So that might be within the specialist community mental health team. But yeah, it is just really important to ensure that there's a specialist psychological offer to all these cohorts of women. So maternal mental health services are encouraged to undertake a local gap analysis and mapping exercise to understand the existing service offer, but also work closely with existing services to clarify pathways, referral criteria, and ways of working that makes sense in the particular local context and that makes sense to patients. Thank you. Next slide, please. I'm very happy to share the slides, by the way. So as I know that many maternal mental health services staff members are joining us today, I just wanted to remind them that there are loads of helpful resources available on the Future NHS collaboration platform. And there's an implementation guidance which supports the testing of the MMHS in early implementer and fast follower sites, but also the development of services in areas that have not yet mobilized. There's an active community on the platform with a dedicated forum. We have created a network as well of people involved who receive regular newsletters. You will also be able to find the an example mobilization plan and the perinatal mental health long-term plan ambitions tools, which includes a MMHS tab and which provides a very helpful checklist of things to do when setting up or expanding a MMHS. There's also a guidance to support the services flow. There are access data to the MHSDS, which is the Mental Health Services Data Set, range of good practice guides and commissioning resources to tackle health inequalities, and also some more like specific resources around perinatal loss. So for instance, Northamptonshire MMHS have done some great webinars on understanding loss and supporting families after loss. So I would highly encourage people to watch these webinars. They're very good. They're available on YouTube and the slides are available on the platform. Next slide, please. Perfect, thank you. And finally, I just wanted to take this opportunity to flag this upcoming webinar organized by the BPS, the British Psychological Society, which will be specifically focused on supporting mental health and psychological well-being in neonatal units. And we're expecting clinical psychologists to present, clinical psychologists who are working within neonatal units and are doing a fantastic job to ensure that parents can access immediate support. And we'll also hear about the new consultant network roles, which aim to improve integrated working with mental health and other health services. And these will be also crucial to ensure that there are smooth pathways, clear pathways between the psychological staff working within the units and the maternal mental health services. Next slide, please. Thank you so much for listening today. Here is my email address. I'm very happy to respond to your questions. I think we're going to have a Q&A today as well. So if you have any questions, you can ask me later or put the questions in the chat, and I'm happy to respond to your questions in the chat. And I'm very happy to introduce our next speakers. So as I said, we're going to have Emily, who's Joshua's mother, who is going to speak about her experience. We're going to hear from Mark, who's the lead for the National Bereavement Care Pathway based at SENS. And also we have the amazing MMHS team from Birmingham and Solihull, who are going to present on their work to set up the maternal mental health service and how they've been working really closely with the specialist bereavement midwife to ensure that there is a good pathway of care in place. Thank you so much for listening.
Thanks so much, Zoe, and thank you to Jenny and others for the invite today to come and talk to you about SANS and the National Bereavement Care Pathway. I'm sure many of you are familiar with SANS and the work that we do. And I'm really delighted that Emily has been able to join us as well. Hi, Emily. And she'll be sharing her story about her journey with her family and with Joshua in a few moments or so, just to help some of the things that I'm going to say to really sort of hit home, I think. And hopefully over the next 20 or 30 minutes, you'll be able to learn much more about what it is that SANS does in terms of our support, but also some of the projects that we lead on, and in particular, the National Bereavement Care Pathway. So my name is Mark, as Zoe said, and I've been working with SANS for almost 5 years now as the project lead for the MBCP, having spent many years in local government. I can see that we've got 130 or so people with us today, and many of those names are familiar, people who I've met over time working with SANS, and many of you are at hospitals that have implemented the MBCPs. So please do feel free to add anything that you think might be helpful into the chat box for those who are less familiar. So if we could move on to the introduction slide, that would be really helpful. So, excuse me, SANS was set up in 1978, and we have 3 core objectives. Firstly, around saving babies' lives, secondly, bereavement care, and thirdly, bereavement support. So the first one is largely obvious. You know, that's what we are there to do, is to help save babies' lives. We were set up as the Stillbirth and Neonatal Death Society in the late 70s, as I say. And over that time, we've seen the number of babies who've died through stillbirth and neonatal death reduce gradually. And over the last 4 or 5 years, that has reduced from 17 babies a day down to 15, and now currently at 13. So we're seeing a really good trajectory. Obviously, it's still 13 too many, of course, and that translates into 4,500 roughly babies who die every year in the UK through neonatal death and through stillbirth. And we share the government's ambition, which is to halve those numbers by 2025, so that by that year the numbers will be nearer to sort of 7 or 8 babies per day. So that is our biggest aim, of course, is about helping saving babies' lives, and we do that through collaboration, through funding research, through lobbying governments across the UK to join us in that ambition. Secondly, in the area we're going to be talking most about today, in my area really, is around bereavement care and ensuring excellent bereavement care for all those who need it. And I'll talk specifically about the bereavement care pathway, but our bereavement care offer extends beyond that. And I'll talk a little bit as well about SANS offer when it comes to training and the resources that we have available for healthcare professionals such as yourselves, those based in a hospital setting and those based outside of hospitals as well, for those professionals who are working with and holding families who are bereaved and on their bereavement journey. So it's about equipping and skilling up healthcare professionals to support families who need it most. And then finally, our third overarching aim is around providing the right bereavement support. And you'll be familiar, I'm sure, many of you, with the local groups that we have across the UK, around 100 of those. Obviously, over the last couple of years, many of those have had to meet online, but we are meeting face to face as well in different areas. We have online portals for online support, the helpline, and I would say at this point as well, just to say that the SANS helpline is there for anybody affected by the death of a baby. So that's not just for mothers and partners and family and friends, but for you as healthcare professionals. If you're finding things particularly difficult after a difficult shift or an experience you've had with a family, please do reach out to SANS and use the support helpline and the other resources that we have available. If we could go on to the next slide then, please. So although SANS is as I said earlier, focused on stillbirth and neonatal death, we thought it would be opportune to talk about baby loss in the context of 5 types of loss, because the National Bereavement Care Pathway, which I lead and that has been set up, covers 5 different experiences of baby loss. And to give it its full title, it's the National Bereavement Care Pathway for Pregnancy, Loss and the Death of a Baby. So actually we're working with partners such as the Miscarriage Association, Antenatal Results and Choices, or ARC, Bliss and the Lullaby Trust, the Twins Trust, other charities, Royal Colleges, institutions and professional organisations to develop pathways which enable the best possible bereavement care after the loss of pregnancy or the death of a baby. So that includes miscarriage, including molar and ectopic pregnancies, termination due to fetal anomaly or termination for medical reasons, as some refer to it as, stillbirth, for neonatal death, and for the SUDI death, the sudden and unexpected death of an infant. So there are 5 pathways, and you can find these on mbcpathway.org.uk. And if there are visitors today, delegates from Scotland, you can find a specific pathway for Scotland at mbcpscotland.org.uk. For Wales and Northern Ireland, a little bit further down the track, and we are working with governments there to try and develop national pathways in those 2 countries of the UK, but predominantly we're working in England and Scotland currently, and I'm delighted that over 70% of trusts in England have now signed up to the National Bereavement Care Pathway. So that's almost 100 trusts now, which is really pleasing, and it's been great to link in with Zoe and with the MMHs over the last 6 months or so to join up those pathways too. So you can find lots more about the MBC pathway on those websites. If we can go to the next page, please. So today really is to talk about SANS, to talk about the bereavement care pathway, and just to give a little sort of glimpse, if you like, into the nature of baby loss and grief. Of course, one thing that is important to say about baby loss is of course its uniqueness in terms of the type of loss that is experienced, and every pregnancy and birth experience is different, of course, so it stands to reason that every grief experience therein is also unique. For some, they will have had some families will have had an okay or a normal pregnancy, so to speak, and now suddenly it has changed. For others, their pregnancy may have had complications all along, and they've had extra worry and stress along that journey. And for others, you know, high risk pregnancies are known about all the way along. So each experience is unique, and in each experience, the loss of their baby will be absolutely devastating. So even knowing your baby is at high risk doesn't, of course, prepare a parent to lose their baby, and nothing does. And even within the same family, of course, for a couple, their experience will be unique themselves, and every interaction affects the parents' long-term outcomes. So the care that they receive at this critical time will be marked in their memories for life. And I know that when Emily speaks in a moment or two, she'll be able to share some of her experience around this. It's important to acknowledge that the physical nature of grief, as there is the physical nature of birth, there's a physical side to grief, and those grief symptoms may include things such as insomnia, lack of appetite, memory problems, headaches, stomach aches and pain, and grief can just be exhausting. Mums may often sideline their own physical recovery as well, whilst they're dealing with the emotion of things and the grief, and maybe in terms of the wider family too. So it's important as healthcare professionals that is acknowledged and managed. So, you know, in your care for families, please make sure you look out for both parents, for the wider family, for dads and for partners, same-sex partners, because they're often overlooked. There's often a feeling of isolation. You know, baby loss, whilst we're talking about it much more than we used to in our society, it is still relatively a taboo subject, and things are changing through Baby Loss Awareness Week and through other initiatives in the UK, but parents often report feeling isolated from family, friends and communities, which is another thing we'll pick up a little bit later on when we talk about parents in the community and the lack of support that's available to them. Often when a parent receives the news, they can feel like they're the only people in the world that this is happening to. So it's important that we remind them that there are supports available to them. Obviously, SANS is one we would promote, but of course there are other baby loss charities depending on what is appropriate. You know, if it's a twin loss, the Twins Trust have a bereavement support group, for example. If it's an earlier loss, the Miscarriage Association. And also to let them know that they have you, that there's a multidisciplinary team there to support and guide them, and that they are not alone. As I said earlier, we must think about the lifelong impact on the whole family. We must consider other siblings that may be part of that family, grandparents. You know, often we talk to grandmothers particularly who've seen their own daughter going through their loss of their own daughter or son. And that can be really hard for grandparents, of course, as they're trying to support their own grown-up child through their grief. Aunts and uncles and the whole community, of course. The death of a baby can send shockwaves through all who know the family. The loss is felt forever, and families will always remember. In a moment, we'll talk about memory making and remembering that the bereavement care that is received, particularly early on in that journey, and those first words and those first steps that are said and shared will impact the parents, the family, and the wider community forever. Because to them, someone will always be missing. Birthdays will still be celebrated, and that loss doesn't go away. And also to say, you know, there is an impact on self-esteem and self-image. Pregnancy itself is obviously a time of transition, and during pregnancy, future plans are changed, and one's self-view can change in line with that. Parents are planning for a future with their baby, and obviously the baby's death can shake all of that to the core. So lots of questions can be asked, you know, for example, am I still a mum? Am I still a dad? What does that make me? So your role as professionals is to support parenthood, to validate parenthood, and to remember that parents share the same sense of pride in their child as any other parent does. So I'd like to introduce Emily to you now. If you could just move on to the next slide, please. Emily, I've got to know over the last year or two. Emily is mum to Joshua, and she'll tell you about her family more widely. And she's a brilliant supporter, not just of SANS, but also of the National Bereavement Care Pathway. And we've spoken at a number of different events together. And I'm really grateful that she's taken time out of her day job today to come and be with us. So I'll hand over to you, Emily.
Thank you. And I am a teacher at a school at the moment, so please excuse the sounds of children that might be behind me as I'm speaking, on the odd bell that might go off. So apologies for that. So yeah, thank you very much for having me. It's always a privilege to come on to these things and share Joshua's story. As Mark said, you know, keeping your baby's name alive and keeping their memory alive is one of the most important things that you can do as a bereaved parent. And being able to come and share Joshua's story and talk about the support that I received, or lack of, actually I'll probably talk about that as well, is going to be really, really important. So I'll start at the beginning. I was one of those pregnancies which was a low risk first time pregnancy. I was seen as, you know, I was going to have a very smooth journey. There were no risk factors at all. I was tested for everything and everything was okay. Apart from the odd one growth scan, everything looked well until in July 2016, the 24th of July, after several weeks of going back and forth, I finally realised that actually Joshua hadn't really moved as much as I thought he would normally be doing in that day. And I went to the hospital and I heard those fateful words that nobody ever wants to hear. And I was 41 plus 6 at that point. So I was well over term at that point. So I think, picking up on what Mark said, that sudden change you go through is instant. You know, you're preparing for a change in your life over 9 months, and you're gradually preparing to bring a baby home. But within about 3, 4, 5, 6 seconds, you're told that your whole world that you've been planning for has completely changed, which is why many parents often go on to later be diagnosed with things such as PTSD, because you're instantly changed. It's an instant trauma. And then you have to face the prospect of what comes next. Now, I actually went into natural labour. I was kind of already in labour anyway, so I actually only delivered Joshua the next day. So his birthday is the 25th of July, 2016. And so I didn't have to necessarily have as much intervention as some parents do, where they have to go home and wait and then come in and take a tablet and all those different things that happen. So obviously my loss is very different to some of the women that I work with, and I'll talk about some of that later on. In terms of support and aftercare, you know, in the hospital, it was really good aftercare in the hospital. There were a couple of things that could have changed in terms of memory making. I probably wasn't as encouraged as much as I could have done, and I've lived with that regret. I think you live with those choices for the rest of your life. My birth with my rainbow baby, who I'll go on and talk about in a minute, I remember parts of it, but actually the feeling of having a live baby in my arms kind of eradicated any of the kind of the difficult parts of that. Whereas when you are going for a birth that is ultimately going to not have a happy ending, you remember every single moment, and I think that's something that's really core and really key. When I left hospital, I was very fortunate in the sense that I had a really good community midwife, but obviously there was only so much she could do. So she was able to do a couple of visits on me until the kind of final sign off, and then I actually had a really good health visitor. After that, though, after kind of the initial weeks, it kind of faded away. I didn't really have anything that could support me. You know, a year later, one of my friends, she got diagnosed with postnatal anxiety pretty instantly after her baby was born, and she had every service thrown at her under the sun. But at the time of Joshua dying, I was handed the odd phone number, but it was all very much me having to actively seek support. And I think that's where the shift has changed now, especially in the Basingstoke area, and hopefully will continue to change through trusts throughout the UK. So in terms of like me and my mental health, you know, I really struggled with change. I really struggled with all sorts of different things. You know, that trauma of being told your baby has died, it instantly changes you. And I then struggled also then to seek support for that, because actually I didn't feel like I was worthy. You know, all that kind of self-loathing you had, you know, all that blame and everything, you kind of don't feel like actually, you know, you just think, well, this is normal now. And that isolated feeling that Mark said about is very real. You know, I wanted to be at home with my baby. I should have been at home with my baby. Joshua should have been there. You know, I'd been carrying him for 9 months and he wasn't. So how do you live a maternity leave like that? So fast forward to me getting pregnant again. That was a huge decision to make. I would say that, yes, we need to support bereavement care, but also rainbow pregnancy care is vital, because you're entering a pregnancy where you are going in with completely different mindset and eyes to what had previously happened. So, you know, my first pregnancy with Joshua, I didn't even think about anything happening. Whereas when I got pregnant with my rainbow baby Edward, who is now 4.5 years old, I was instantly thinking that everything under the sun was going to happen. And the fact that the idea of carrying to term and actually having a live baby was just insanely difficult to even comprehend. So again, I had a really good community midwife who supported me through that and supported me through that journey. But I know that's not the case for everybody, and that kind of reassurance you need. I would say that some of the real challenges you face are the fact that people still question you along the way. So I would go for extra scans, and each time I would have to explain my story again and again, because people wouldn't read my notes quick enough. You know, I would have a SANS sticker on there, and I would have highlighted. My community midwife ended up like highlighting every single aspect that said that I'd had a term loss previously. But I would still, to receptionists and everything, okay, why are you having an extra scan then? Or, you know, someone innocently coming to check bloods, you know, is this your first baby? And all those questions kind of add to that pressure of, well, I feel different, you know, I have to retell my story again and again. And you want to tell your story, absolutely, but you want to be in control of when you tell that story. So following the birth of my rainbow baby Edward, I really realized actually that I wasn't okay. Like, I hadn't been given the support I needed, which is when I eventually embraced SANS and found SANS. And, you know, but again, that was me seeking out support. I found SANS, thankfully. the support they gave, and going to meetings and just starting to talk to other parents made me realise that actually I wanted to help with that support. So in 2019, I actually trained as something that we call a befriender. So a befriender is where a bereaved parent, it doesn't have to be a parent, it can be anyone kind of in the bereavement world, but it's mainly bereaved parents. We had an aunt at ours, and there's a grandparent at ours as well, our training. You go along and you learn ways to talk to other bereaved parents, which may sound crazy because you're thinking, well, you're a bereaved parent yourself. But even I, as a bereaved parent, won't necessarily know exactly the best ways to speak. And actually, not every bereaved parent can do it either. It's quite a rigorous interview process to get through before you even get to that point. You know, you have to be 2 years out of loss and all these different things. And that was really important. And I think that peer support is just as important as the medical support you get and from the clinical teams, because actually, being able to talk to someone that's been through a similar experience to you, not necessarily similar in terms of term, but as in like losing a baby, which is a very unique experience, is vital and key. So obviously COVID and lockdowns, etc., kind of have put a blocker on things, but I eventually started working really closely with our amazing bereavement midwife who's actually on this call right now. So Laura Mackey, I worked with her at Basingstoke, and I eventually we kind of worked together to set up, beyond just the support meetings, a clinic that we run, and it was supposed to be monthly, it's now weekly, which is where I go in and I talk to other bereaved parents one-on-one, and it's a kind of a vital part of our service now that we provide along the bereavement care pathway. You know, there's this kind of checklist now where we go, right, does this person actually need peer support? Do they need to actually sit and talk to another bereaved parent? And often that is something that some parents don't necessarily need the counselling straight away. Sometimes it's that we actually just need to talk to someone. And I found that because I was so isolated when Joshua died, that actually if I'd been able to sit in a room in the weeks, months after and just find out that me feeling guilty wasn't an unusual thing, and that those thoughts going through my head wasn't, you know, all those different thoughts you have, and actually my friends suddenly starting to not being able to talk to me properly, is that normal, is that okay? And you know, all those things, all those reassurances that we can now give in our Befriender clinic, our peer support clinic that we now run. So that's kind of where it's transitioned to, and my motivation for that has always been Joshua and supporting my mental health, because actually working with, it's funny enough, and I always say this to Laura, it actually supports my mental health being able to work with other bereaved parents, because I know that Joshua's story is doing good. You know, he should be here. So what can I do in his name? Well, I can help other people, you know. And I really do think that along the way, supporting mental health is, yes, the clinical side of things and counselling, and we do refer counsellors as well, but sometimes just being able to talk to someone and know you're not alone is key and important. And so now I support women in their bereavements, but also in their pregnancy after loss as well. So there's women that I speak to who are going through that journey, obviously having gone through it myself, but just that peer support is really, really important. So yeah, I think I've covered everything, but obviously if there's any questions at any point, then let me know. I'm staying on the call for a little bit. So yeah, hopefully I've been able to help.
Thanks so much, Emily, and you've got a lot of love. There's lots of hearts sort of arriving on the screen as people are
Thank you.
Sort of reacting to what you've shared, and there's some lovely comments as well about how inspirational you are and what a legacy Joshua has left behind. And yeah, just really grateful again for you sharing your story, which isn't always easy.
Pleasure.
I know it's not always easy, but I know it's a pleasure, absolutely that, and that you enjoy doing that. And as I was saying earlier, it's about validating your parenthood, isn't it? And your mothering of Joshua continues, although sadly he has died. This is part of how you continue to mother him, by sharing his story and by making sure that others are supported in their bereavement journey as well. So thank you so much. And there's many Emilys out there, obviously, as we said earlier on. You know, although her story and her family's story and Joshua's story is unique, there are many parents who do like to share their story. And one of the things I'm going to come on to say to you is ask their name. ask a bereaved parent what their baby's name was, rather than sort of shying away from that. And it's so meaningful because it gives validity to them and to their child. So thank you, and do chip in as I carry on, Emily, and we'll see if there's any questions as we go through. But if we could bring up the next slide, that would be really helpful. I mentioned obviously the National Bereavement Care Pathway, and if we had longer, I'd talk about each of these 9 standards in depth. The 9 bereavement care standards have been developed over the last 3 or 4 years. These are standards that we ask all trusts who sign up to the MBCP to really aspire to. If you sign up as a trust, it doesn't mean that you're there and that you've reached these 9 standards, but that you're on a journey to trying to attain these. So I'll just go through them very quickly, and I'll land on 2 or 3 of these. The first 3, sort of in the top right, are based around the parent. The reality is all 9 are, of course, but informed choices, making memories, and bereavement rooms. You know, it's our strong belief, and working with healthcare professionals. Some of you are on the call who helped us to pilot the MBCP between 2017 and 2019, as well as parents and professionals, have helped us to acknowledge that these 3 are so key to parents, giving informed choices. So giving them the opportunity to make choices, even in such a sad time, whether that's around something like a post-mortem, whether it's around the support that they can receive in the community, whether it's around taking the baby home with the support of a cold cot, for example. Again, it's that thing of helping to validate parenthood by enabling parents to make those choices and take those decisions. The opportunity to make memories, I've got a slide on that, so I'll come back to that in a moment or two, but it's so crucial, as we said earlier, the opportunity to spend time with baby and to make memories. Bereavement rooms or bereavement suites, I know many hospitals have these, particularly in maternity, for after a baby has died, but also if you think about it in the context of other types of loss, are there bereavement rooms or facilities or spaces where parents can go, mothers can go after an anomaly scan when they're receiving bad news earlier on in pregnancy, or when there's, you know, when a baby is miscarried, or, you know, there's another type of loss, be that in neonatal or maybe in an accident and emergency, because of course not every journey is exactly the same, and as we know, parents and patients access hospital and other services through different doors, don't they? So it's making sure that those rooms and spaces are available. The next 3 are based around healthcare professionals. So, you know, we strongly feel that there should be a bereavement lead, someone who is responsible for overseeing all bereavements with regards to baby loss and the death of a baby within a hospital trust, not just, inverted commas, just bereavement services that deal with all types of death, but because baby loss is so unique, such a unique experience, it's really vital that someone leads on that. They commission training, that they ensure standards are met, that staff are being trained, that facilities and resources are available, and that bereavement care training is available too. And I've got a slide on that in a moment. But that healthcare staff are given support and resources in order to do their job as best they can. And it's brilliant, the development of the maternal mental health hubs and the resources that are being provided through that. And increasingly staff in the hospital setting are provided with resources, be that things like a cold cot, or be that manuals, you know, the SANS guidance for working with families after the death of a baby, or the ability to access e-learning modules, for example, or leaflets, information, etc. But also that healthcare staff have support from their seniors, from their peers after a particularly difficult shift. Yes, it's important that we learn lessons from what has happened, but also it's important that you have an out. We talk about that in SANS a lot with healthcare professionals, that you can't pour from an empty pot. So it's really important that you top up your pot, so that you are able to talk to others as well. And again, just to say, as I did earlier, that the SANS helpline is there for you too. That there should be a bereavement care plan, like there should be for any healthcare plan, a plan which sets out what the next steps are, what decisions have been made, what support parents have been offered, and what they've decided to take on board, and to ensure that, related to that, there's a system to signal that there's been a bereavement. And particularly, I think, for those of you working in multidisciplinary teams and where mothers have been referred on to you, maybe from hospitals, that it's clear why that is the case, that information systems talk to each other. You know, Emily talked there about the fact that despite that in the settings that she was accessing, you know, there were big notes in bold or highlighted saying there has been a loss, she was still asked the question by the receptionist or by the sonographer and others, you know, also, why are you here? You know, what's special about this pregnancy, etc., etc. And they're sort of well-meaning terms, but actually can cause difficulty, and to revisit that scenario again. And you know, bereaved parents, where possible, don't want to have to keep repeating that story and the memory of the initial loss. Not that they don't want to talk about their baby, but actually it can be a trigger for many as well. So making sure that those signals are in place, be that electronically or on paper notes. Some of you will be familiar with the SANS teardrop sticker that's put on mother's notes, for example. And then finally, and particularly important related to today's topic, is around assessment and referral, and making sure that mothers and their partners, as we said earlier, are assessed for their emotional and mental health needs and are referred on to relevant support. You know, SANS has peer support groups, befriender groups, as Emily's mentioned, but at the moment we don't provide counselling, but maybe that's something for the future for SANS, but other organisations do, and we recognise that counselling is a very patchwork of provision across the country, which we'll come on to in a moment or two again. But yeah, just making sure that the appropriate referral is made after an appropriate assessment is made also. If we can move on to the next slide, I'll just pick up 2 or 3 of these in a little bit more detail. I mentioned about making memories, and for some that might seem like quite a strange thing to do, as that quote there from one bereaved mum said, you know, I didn't really want to have photos taken at the time. Why would I want to remember any of that nightmare? But honestly, I wish I had more pictures. The details in his hands, his feet, his little ears, I wish I had more. They can be so helpful. So just for professionals, you know, obviously some of you are bereavement midwives, some of you are based within a hospital setting, and so will have experience of this, but just, you know, for awareness of others, really, those can be really precious times, you know, taking videos, providing a teddy bear or a different type of keepsake in a little memory box. There's a little photo there of the memory boxes that SANS provide for free. You know, handprints can be taken, a lock of hair taken and put in a memory box, memory books, birth certificates, but above all, the opportunity to spend time with their baby, you know, taking baby home, having music played, bathing, bathing the baby, and having family to visit where appropriate too. These are really precious memories. The baby will only be there for a short period of time, obviously. So, you know, when healthcare professionals are able to create the space for that time and those things to take place, it's a wonderful thing. So that's making memories. And if we can move on to the next slide, another one is around training, as I mentioned. And everybody is welcome to join any of the SANS webinars that we provide free of charge, or indeed our team can come out to hospitals and to any setting. We'd be happy to bespoke any training to hubs and multidisciplinary teams. So do get in touch with us if you'd like that to happen. Restrictions dependent, of course, but we can run them online too. But there's some free e-learning modules too, and this is the e-learning for healthcare module. If you just Google ELFH, e-learning for healthcare, many of you will have a login for that platform anyway, and just go to bereavement care pathway, you'll find it. And there's 2 modules there. One is a very, very short introductory module for all, it's 10 minutes. For anybody. So we've had cafe baristas in hospital cafes taking it, porters, receptionists, you know, those who you wouldn't necessarily target for training. And MPs have done it as well. But teachers could do this as well, you know, Emily, in your school, obviously, or you know, if you know social care teams, anyone who's going to be in touch with a bereaved family, it's just an introduction to saying their name, saying the words. And then there is a second module that's a bit more focused for healthcare professionals. And thousands of these modules have been completed since we launched it in 2019. So please do access those. If you can go to the next slide, please. It's a bit of a carousel today. I'm talking about SANS, I'm talking about bereavement care pathway, I'm talking about training, but also was asked just to touch a little bit on the types of thing that might be helpful for those of you who are not used to working with bereaved families, or those of you who are, and just a bit of a refresher really. So these are some of the phrases that bereaved parents talk to us about that they say are not helpful and which are helpful on the subsequent slide. So things like trying to say, well, maybe it was meant to be. You're still young, you've got another chance. At least you didn't get to know him or her properly. Time's a great healer. You'll be back to normal soon. You know, these probably come from a good place and are meant to be well-intentioned, but are obviously ideally avoidable. Instead, some of the phrases that you could use are on this next slide. What was your baby's name? Like I said, what was your baby's name? Tell me a bit about Joshua. Tell me about your story and your baby's story. I'd love to hear it. Do what's right for you. We're here to support you. Do take one step at a time, one day at a time. Support is available to you, but you don't have to access it. Use what's helpful to you and just put aside what's not helpful. I and our team are here for you. So these are just sort of 5 or 6 examples here of what's useful to say and some of the things maybe to avoid as well. And these are taken from SANS webinars. As I say, we do some free webinars that you can find on our new SANS training microsite that's recently been launched, and or for the sort of the full day training that we can come out and do as well. If we go on to that next slide, please. I mentioned about our resources that are available and our training materials, and I can see in the chat box, thank you to those who've said, you know, we've had some excellent training from SANS. I can see it sort of pinging up here. That's really good of you. Thank you, Donna. Yes, the SANS professional webinar, highly recommended. And Amanda at East London was saying that SANS training was excellent, and others too. So thank you for that. And I'll try and go through the chat box and pick up any questions during the next bit of the session. But yeah, you can find lots of information on the SANS website and on the MBC Pathway website as well about memory making, about communication, about our support services. If we go on to the next slide, please. The MBCP, many of you work in or with trusts that have already signed up. As I said earlier, we've had 100% of trusts in England have expressed their interest in the MBCP, which is brilliant. So we're in communication with every hospital trust. And as I said, over 70% have now actually signed up, which is free of charge. And you get access to different resources and materials there. So do get in touch via the website if you'd like to know more. And we're obviously working really hard to try and get up to 100%. And I know that Laura is on the call from Hampshire and others from Sussex and Leeds and Derbyshire and other places that have already signed up to the MBCP and were part of our pilot programme as well. So please do use the resources there. It's very much a collaborative programme. If we go to the next slide. And really just to sort of finish up by joining this back up with some of the things that Zoe said earlier, and I know are going to be part of the final session in today's webinar. It's the bit about psychological support. So I've talked predominantly about sort of that bereavement care journey in its early days within a hospital setting, but actually, as we said, the bereavement and that grief can and does last a lifetime. So it's important that parents aren't left alone, and that they are supported and not left isolated, as Emily's touched on and Zoe talked about earlier. And this report that we commissioned and that we wrote with our partners at the back end of 2018 for Baby Loss Awareness Week, called Out of Sight, Out of Mind, showed that 60% of bereaved parents felt they needed specialist psychological support for their mental health, but were unable to access it. If we go to the next one, please. I suffered from PTSD as a result of my daughter's birth, and it took me 4 years to get a diagnosis. Everyone kept saying I'm grieving and needed counselling, but no one really listened to me to see how severe my symptoms were. And these are a number of quotes that we've got here. If we get onto the next one, you know, that one saying I felt a failure as well. Very difficult. So these were the things that we were calling for that needed to be changed in terms of awareness, assessment and referral pathways. If we can click to the next slide, please. Yeah, commissioners in over 86% of areas told us they do not commission specialist therapies to support bereaved parents. And one parent said, I didn't want counselling whilst in hospital. It was too soon. I was struggling to process what happened. I was only in for 4 days after the twins passed away. I asked for a few weeks after I was discharged, only then to be told it was too late. So it's about trying to personalise that care, base it around what the parents need, not what fits our frameworks, if you like, or what's convenient to us. And obviously some of this brought about some of the changes and some of the development of the MMHH, as Zoe said earlier. If we can go to the next slide. The quality of services was talked about. The counsellor was one-dimensional and unable to adapt. I could only manage one meeting. We had to return to the hospital and walk through the maternity unit. So again, we hear this a lot about sort of our processes are in place whereby parents have to return from whence they came, and that can be incredibly triggering. So again, just a simple thing about acknowledging where the parent's been and saying, would you like us to meet in a different building? I'll do my best to access a room off-site or in a different building on the same site, so you don't have to go through those doors again. Just something simple like that can make a massive difference. Next slide, please. And the research said, that those who experience stillbirth, miscarriage or ectopic pregnancy are at higher risk of PTSD. A significant proportion of women suffer from symptoms of PTSD after losing a pregnancy, and 1 in 3 women showed a clinically significant level of post-traumatic stress symptoms even 5 to 18 years after stillbirth. And we've quoted the 60 to 70% of grieving mothers also. So yeah, there's a lot of statistics there that highlight the need. And then I think we've got 1 or 2 final slides. If we could just click onto those, please. There are a couple more quotes there. Bereaved dad at the bottom there. Expressing your emotions as a father who's lost a child is difficult. The emphasis at all stages on the mum, which I totally get. However, I feel further support could be provided for me as a dad or as a same-sex partner. So, you know, these are really important quotes, and you will get the slides afterwards, so you can go through these in more depth, and you can access the Out of Sight, Out of Mind report on the Baby Loss Awareness Week websites. And we go to that final slide. So a real whistle-stop tour in that half an hour. Thank you so much again to Emily for sharing Joshua's story and to help sort of illustrate some of the points that I've been trying to sort of theoretically make as well. I'm sorry we've gone a couple of minutes over. There's the contact details. You can email me. You can access all that information on the SANS website and on the MBC Pathway website, and as I said as well, the MBCP Scotland website too. So please do get in touch. As I say, this has very much been a collaborative project. So, you know, it's constantly shifting, it's dynamic. We're in the process of updating the guidance, ready for new publications to come out in March. So look out for those, and do feedback on what helps you and what doesn't help you, because really what we're here to do with the bereavement care pathway is, as I said earlier, to equip you as healthcare professionals to care for parents in the best way that you possibly can at such a traumatic time. Thanks for listening, and I'll try and pick up some of those questions over the next half an hour in the chat box.
Oh, brilliant. Thank you, Mark. There's a little bit of an opportunity now because we're just switching over to the film, which always just takes a minute or two. So I just wonder if that's a quick win about the standards included for mental health trusts. Is that, a couple of people have asked that question?
Okay, so I haven't put that in there at the moment. I haven't sort of seen that question yet, but is the question that do the standards apply to mental health trusts?
Yeah.
We are, the thing with these standards is they're not mandated centrally. The government has, in their words, they strongly endorse the MBCP and strongly encourage all trusts across the UK to adopt the MBCP and its standards, but they haven't mandated them. So in the first instance, we're working with hospital trusts to implement these standards. It's voluntary at the minute. We continue to lobby government or governments across the UK to adopt these standards and to mandate them. So they're not mandatory, they're voluntary, but I think, and clearly those 9 standards are developed predominantly from the hospital setting, but clearly the majority of those would apply outside of a hospital setting as well. So we'd love you to adopt as many of those as you can. And if you want to get in touch with me, I can share some resources with you that would help to demonstrate how you're able to implement those outside of a hospital trust as well.
That's brilliant, thank you. And there's another one from Lisa Beasley, which I think is probably quite an easy one for you to answer in the chat. So
okay,
I'm going to disappear again now, and I will hand over to the film from
Thank you so much.
Birmingham and Solihull MMHS. But you've got no sound at the moment, Liz.
Jenny, can you just fill the gap a little bit whilst I work that out? Is that okay?
I shall do a so yeah, just while Liz is sorting that out, I would remind you of all the amazing publications that Zoe signposted to at the beginning, and we'll probably be a bit pushed for time at the end, so I will just highlight a couple of resources. The first one that may have passed you by, because certainly I didn't become aware of it until a week or so ago, is the vision for the Women's Health Equality Strategy, which obviously is very relevant to everyone on this call. So the vision itself was published on Christmas Eve, so I think we've all got a pretty good excuse for not noticing it if we didn't notice it at the time. And then the full strategy is going to be published early spring. We don't have an actual date for that one, so I would definitely say look out for that. There's a lot in there around obviously perinatal maternity and the agenda of the maternal mental health services. So look out for that one.
I think we're ready to go. So if people can't hear, can they just put it in the chat? Thank you very much.
Really excited to be able to talk to you today about. Hello, I'm really excited to be able to talk to you today about a new maternal mental health service in Birmingham and Solihull. So I'm sure the presentation will generate lots of questions, and I'm really sorry that we can't be there, but we've left our email address at the end. So if there's anything that comes up that you want to talk to us about or have more information, then please get in contact with us after the presentation. So next slide. So I'm going to run through what we're going to be talking about today. So I'm Samantha Day, I'm a consultant clinical psychologist and I'm the clinical lead for the new service. So I will be talking briefly about the setup of the service, our criteria and what we currently offer. So Sophie is the specialist midwife in our team and she'll be talking about her role and her current projects. And Alison is the specialist bereavement midwife at Birmingham Women's Hospital, which is the biggest birthing hospital in Birmingham. And she'll be talking about how we work together as part of a team. Next slide. So just to give you a context of our situation in Birmingham. So we were lucky enough to be an early implementer site for the maternal mental health services. We went live in April 2021. So in that time, we've been building the team and we just have one vacancy for a clinician at present. So perinatal mental health services are really well established in Birmingham and Solihull. So we have a mother and baby unit, and we've got 4 community teams which cover all the hospitals in Birmingham and Solihull. So what's important about these great perinatal services is that they don't look after women who lose their pregnancy or their babies. So in Birmingham, we've got 3 birthing hospitals covering around 20,000 births a year. Sorry, and next slide. So as part of the bidding process, we ran a lived experience group to find out from women who had experienced perinatal loss what was really important to them about this particular service. So what we learned about the experience of being discharged following baby loss from the community perinatal teams, that it's a very abandoning experience for women at a really difficult time. We also heard that although we're really well equipped in Birmingham and Solihull with 2 third sector organisations providing counselling for perinatal loss, women were concerned about their mental health and wanted a service that was able to hold the complexity of this. We also heard about the gap in services for partners and also family members, other family members who were affected by perinatal loss. So women spoke about the timing of the interventions also, where different people need different things at different times. So women wanted to be able to access a service like this at any point following the loss, not just in the first 6 months. We also learned that women really value peer support, being able to talk to someone who had survived the experience and was able to share support, resources, and hope that things will feel easier in time. So another important thread in the creation of our service was the data of perinatal loss in Birmingham and Solihull. So the number of babies dying in Birmingham is a bit less than double the average in England. So reasons put forward to make sense of these figures is that Birmingham has high levels of deprivation with a higher than average amount of babies of non-white ethnicity. So looking at our figures, we can see that there's a higher incidence of stillbirth and neonatal death amongst Pakistani women, white other than British women, and Black African women. It has also been shown in research that non-white women are more likely to experience perinatal mental health illness and less likely to be able to engage in treatment. So the gaps in provision for families that we found when scoping for where this new service should fit were women who were discharged from the perinatal mental health teams after losing their pregnancies or their babies, women who were held by the bereavement midwives who had moderate severe mental health difficulties, and the only avenue for support was the community mental health teams. Families being discharged from the neonatal ward, where we know there's a very high incidence of PTSD, but not knowing what support was available. Women feeling as if the third sector organisations are not able to manage the complexity of their mental health presentations, and families from non-white ethnicities feeling as if their needs were not being represented, and finally across the board feeling as if partners were not being included. So given all the information we gained, we put together our initial offer. So we provide evidence-based assessment and treatment for women who have experienced perinatal loss and have associated mental health difficulties such as anxiety, depression and trauma symptoms. We provide NICE supported treatments such as cognitive behavioural therapy, EMDR and dialectical behavioural therapy in the form of emotional coping skills. We also have 3 peer support workers who are hosted from local organisations who have been able to engage communities that are particularly affected by perinatal loss. So they're able to provide support to women through the course of their treatment in the service. The peer support workers have lived experience of perinatal loss and act as a bridge between us and local services, and are also able to bring the lived experience voice into all our meetings and to ensure that it's central to everything that we do. It also means that because of their connection with local services, that the jigsaw of support for families feels more joined up. We also offer partners a mental health assessment with signposting to appropriate support. Another strand of our work is around supporting the input of psychological understanding and trauma-informed care into the pathways within maternity, particularly around perinatal loss and birth trauma. So we're currently looking at the neonatal pathways to ensure families whose babies die know what support is available and how this support is joined up. We are offering midwives within the bereavement pathways, individual and team supervision to provide a reflective space to support with the impact of the work. And we have organised training within maternity, such as a 5-day training in interpersonal therapy and also in birth trauma. Finally, we've got lots of ideas about research we'd like to do. So we are supporting trainee clinical psychologist projects on British Pakistani women's experiences of support following perinatal loss, and also British Pakistani men's experience of support following perinatal loss. So our referral criteria, so we assess women who present with moderate severe mental health difficulties associated with the loss, mainly PTSD, depression, anxiety and complicated grief. Women are referred through bereavement midwives, perinatal mental health teams, GPs and IAPT. So perinatal loss for us is recurrent infertility, miscarriage, termination, stillbirth and neonatal loss. So it doesn't matter in terms of referral to our service how long ago the perinatal loss was. We also see women who are pregnant and need additional support through the pregnancy due to the mental health difficulties which have been impacted by previous losses. So we're a small team, so we have clinical psychologists, peer support, a specialist midwife, project manager, assistant psychologist and an administrator. We also have a counsellor vacancy which we're hoping to fill soon. So I'm going to pass over to Sophie, the specialist midwife in our team, to talk about her role.
Hi, thank you, Steve. My name is Sophie Garcia. I am the specialist midwife, obviously within the new MMHS team. Next slide, please. I commenced my post last year in September, at the end of September, and I have a background of working on delivery suite and on the bereavement suite at Heartlands Hospital. Within this role, I am the bridging gap with knowledge, awareness, and also transferable skills between the mental health sector and maternity sector. As I think, especially coming into this new role, it became apparent actually how big that gap was. I've also been making connections with the other MMHS midwives nationally and seeing how different areas are providing different services. And I've also been a point of contact for staff about referrals, advice, support and information to signpost women. Next slide. I have started working clinically once a week. I work on a Wednesday and I'm quite flexible within where I can work. So if there's, as I'm sure you're aware, there's shortage of staff if they need my support. But mainly I work within the bereavement suite at Heartlands. I'm also hoping to go over to the women's with Alison to meet some of their new staff that they've got starting soon. So as I said, I work a clinical shift a week on the bereavement suite, but I also help run the Rainbow Clinics at Heartlands. We have now established Rainbow Clinic where we see women in their subsequent pregnancies who've had a previous loss, mainly due to placental issues. There's lots of different routes for the different women with the different kind of losses. I've also been working alongside the PMA midwives to provide support to staff and to also support them in anything that they need. And I've also been looking at building those working relationships with the midwives to kind of start to understand the services that we provide, but also the models that we use. Next slide, please. So my current projects that I've been working on a video that we're looking at creating that can be shown by a multitude of professionals that can help women, their families, their partners, but also staff to understand the experience that parents can go through after they've experienced a pregnancy loss and the routes of support that they can access and how they can go about accessing that. We're looking to establish some anxiety management groups for the Rainbow women going through the Rainbow Clinics, which will look at managing their coping skills, emotional coping skills, going in through their pregnancy and into their labour, and how we can facilitate that alongside their partner or their birthing partners. We also ran a staff event during the Baby Loss Awareness Week, as I think sometimes it's forgotten that as midwives we are women who experience baby loss ourselves, and then we're working quite closely with women then going through it and the midwives' experience of that. And then also the care of midwives, it's obviously well known that 1 in 3 midwives are experiencing PTSD themselves from what they've experienced at work. So looking at building up those guidelines and those care pathways so that midwives are aware and it's easily accessed support that staff can go to. Next slide. So future projects, we're hoping to, as Sam said, increase the birth trauma training around loss, but also birth trauma in general for maternity staff, because I think that's something that's really lacking in the mandatory study days that we do. However, we are having to put that on hold slightly just because of the staffing shortages, and midwives are not being able to attend the mandatory training at the moment because of the staffing situation. And also looking at linking in with gynecology, looking at these women who are experiencing early miscarriage, who maybe are getting missed, with telephone follow-up support for these women, so that they do know that we are there for them. Next slide, please. So I'll pass you over to Alison.
Thank you, Sophie. I'm Alison Ray. I'm bereavement midwife at Birmingham Women's Hospital. Next slide, please. So we are, as bereavement midwives, ideally placed to provide emotional support to families. We receive referrals often even before a baby has died in the case of an anomaly diagnosis or termination of pregnancy, or when care for a baby on our neonatal unit is being moved to palliative. We often see families also from gynecology, after early pregnancy loss, ectopic pregnancies, repeated miscarriage, and we will endeavour to see all of our families who are experiencing stillbirth and late miscarriage on our main delivery suite. The contact with our families moves with them through their journey, and we're often the link between the settings in the hospital and beyond, and we provide a constant supportive presence and also accurate, honest information for these families. As the days, weeks and months go by, bereavement midwives are available to families as a point of contact and continue to provide that emotional support. This often allows couples time to talk outside of family and friends with a trusted health professional who knows their history and is usually likely to have met their baby. Bereavement midwives will very often have extra counselling skills and advanced communication skills that are vital for holding and supporting these families and ensuring that they are looked after in a safe way. Alongside this, there is an excellent array of voluntary sector support. This is now at a level where there will usually be a good fit for most families. And as bereavement midwives, we must ensure that what is recommended to our families is quality assured and safe. We form solid links with these support charities and groups and provide information for families on what is around locally and nationally. Next slide, please. However, we know that many women will experience a worsening of a pre-existing mental health diagnosis or a new or first episode triggered by the events of their loss. This experience could often be very frightening and add another layer of distress to what they are going through. We really value having specialist mental health experts now as part of our wider team, and we are referring women on a weekly basis. And those women are women that are experiencing all types of pregnancy loss, repeating miscarriage, early pregnancy loss, termination of pregnancy for any reason, stillbirth, neonatal death. We are offering those referrals to women that are experiencing depression, anxiety, unhelpful coping strategies that are sustained and are not responding to what usually works for them or simple self-help advice. As bereavement midwives, we don't have the skill set or the capacity to provide long-lasting support. We will always be available for our families, but we have to make sure the care that we're providing is safe. We will act as a gateway to expert therapeutic health with the Maternal Mental Health Service, and we are absolutely delighted to be working with this team and have them in our toolkit to be able to help our families. Thank you. I'll hand you back to Sam now.
Great, so I hope that's given you a bit of a snapshot about what we're wanting to provide. Again, so sorry we can't answer any questions. If you do have any comments or any questions, then please get in contact with us. So I've left the email address of our project manager, Kathy, who will be able to answer all the questions and seek sort of information from the rest of the team as well. All right. Well, yeah, thank you for having us, and yeah, thank you. Bye-bye. Really excited to be able to talk to you today about. Hello, I'm really excited.
That worked really well for a pre-recorded one. We haven't done one like that before, so thank you so much to the gang up in Birmingham for doing that. We've got some resources at the end which we don't actually have time to go through. So what I would say to you is please look through, because there's some useful things on there. And for South East colleagues, there's a couple of notifications about some training. So I'm going to hand back to Zoe now, just to sort of sum up. And I think we've probably got time for a couple of quick questions, because we've got 5 minutes. So there we go. Over to you, Zoe and Mark.
Thank you very much, Jenny. Well, I hope everyone found this webinar interesting and insightful. As Jen said, I would just highly encourage people to look at the resources. There are loads on the Future NHS Collaboration platform and also on the SANS website. And I'm very happy to take any questions.
Oh, we've got a hand up. It's Rose Firth from Somerset.
Hi, thank you. It wasn't a question, it was just say thank you very much. It's been a really, really helpful time today, so just thank you.
Thanks, Rose, that's lovely to hear. And a massive thank you to the team in Birmingham as well, because they were not able to attend today because they were attending training. But I thought their presentation was really good and very insightful regarding the work that they're doing with the MMHS. Thanks to them.
We've got another hand up. I can't see the name, but I think it was Katie from the Black Country. There.
Yeah, hello, hi. Thank you for an excellent presentation. That's been really, really useful. And I look forward to receiving the slides. I just wanted to ask if anyone else was interested in perhaps coming together to think about how we're about to go live. We're a fast follower site in the Black Country. We've still got, I feel, quite a lot of work to do around sort of co-production. And I really want to get this right. So we've started to build relationships with our sort of third sector partners and agencies in the Black Country. But I guess the next step is perhaps around doing some focus groups or some research. But we're at the very early stages of this, and I just wanted to express my interest here really in linking up with anyone else who's at a similar stage in their journey. So I can put my email address in the chat.
Thanks, Katie. Are you using the Future NHS Collaboration platform as well?
Yes, we are. We have got access to that, so I can.
Because there's there's a dedicated forum for maternal mental health services, which is actually quite active. So you can also put your question on that, and I'm sure people will be interested in sharing information with you.
I will do. Thank you. Thanks, Zoe.
And I've just got a question, Zoe. So if the people that are setting up services are sort of looking at bereavement and loss, how do you see the birth trauma element fitting into that, and vice versa if there's a MMHS that are focusing more on birth trauma? Because obviously we can't do one at the loss of the other one, sort of thing. So how do you see that working?
Yeah, so so the long-term plan ambition made very clear that locally, people had to identify gaps in existing service provision, even if, nationally we heard about gaps regarding birth trauma, PTSD and mental health issues in relation to birth trauma, tocophobia, and mental health difficulties in relation to perinatal loss. These were the main cohorts that were identified. So MMHS really have to work really closely with existing services, including perinatal mental health community teams, to map what is available to these women. So, for instance, if the perinatal mental health community teams, because they are expanding and they will offer more psychological interventions, they may offer support to women who have suffered from birth trauma. And if that's the case, then the MMHS can perhaps focus on perinatal loss and tocophobia and other conditions and conditions. But if it's not the case, then it is really important for the MMHS to also focus on birth trauma, because otherwise there will remain a gap of service provision, and women won't be able to access the specialist help that they need. I hope that is clear enough. So
really clear and helpful. Well done. Thank you, Zoe. Trudy, could you pop your question in the chat? We will make sure it's answered, but I know that people are so tight for time these days that we try not to run over. So if you
question, it was just going to say a little bit about what we're doing in Northamptonshire as we were early implementer, and how we're sort of navigating around these sort of issues, particularly around birth trauma in an antenatal phase, and how we're now progressing into our maternal loss pathway.
Well, it'd be great if we can have your details in the chat, if you don't mind, Trudy, and then we could sort of link people up with you, if that's okay.
Yeah, of course. Thank you.
Brilliant. Thank you very much.
Lovely. Thank you very much, everybody, for joining us today. Appreciate we've run a minute or so over, but a really, really thought-provoking morning with fantastic speakers. Thank you to everybody that's given up their time to be here, and so important to also have Emily's story and make it real for all of us. So thank you all. Please do join us for the next webinar on the 23rd of February. We'll be focusing on marginalised groups at that webinar. Further details to follow, but thank you and wishing you all a good rest of the day. Take care. Bye-bye.
Thank you.
Thanks, everyone. Bye.